Thank you, everybody, for joining us. We really appreciate your time, as Wendy mentioned. I know you're all busy, and your commitment to the importance of self-regulation is really important. And we appreciate you being here. My name is Sonia Bruin. I'm the Assistant Registrar of the Quality Department at CPSM. And as you know, our mandate is safe patient care to protect the public. Thank you again for being here.
Hello, I'm Dr. Courtney Leary. I am a medical consultant for the Restorative Practices Program here at the college. I'm a First Nations physician, originally from Norway House, Manitoba.
Hi, my name is Tara Myron. I'm from Home Plain First Nation. I am the CPSM as a knowledge translation and vocalization specialist.
And hi, everybody. I'm Dr. Jason Salfman. I'm a white settler male based in Winnipeg, and I am a medical consultant with the Restorative Practices Program. And it's our pleasure to welcome you to our webinar, The Power of Participation, a Restorative Approach to Anti-Indigenous Racism in Medical Care. And we want to start with our land acknowledgements. And we acknowledge that the CPSM regulates the practice of medicine on the treaty territories of Treaty 1, Treaty 2, Treaty 3, Treaty 4, Treaty 5, and Treaty 5 adhesion. We recognize these are the ancestral lands of the Anishinaabe, Anishinaabe, Cree, Oji-Cree, Dakota Oyate, Dene Suline, and Netawak nations, and the national homeland of the Red River Métis. We acknowledge northern Manitoba includes lands that were and are the ancestral lands of the Inuit. CPSM acknowledges and apologizes for its role in contributing to the disproportionate health inequities that exist among Indigenous communities in Manitoba. These failures include inadequately addressing Indigenous-specific racism by medical practitioners. We respect and celebrate the resilience and strength Manitoba's Indigenous peoples have displayed in the face of genocide and displacement of their communities. It is a privilege to regulate the practice of medicine on these lands, and CPSM pledges to improve. The first step to improving is continual acknowledgement of our respect for the spirit and intent of treaties, and remaining committed to working in partnership with First Nations, Inuit, and Métis people in the spirit of truth, reconciliation, and collaboration.
So why do we need and why do we have the Restorative Practices Program? To get a bit more information, we're going to go into a little bit of the history of it, and I'm going to get Eric to do that.
So 10 years ago, the Truth and Reconciliation Commission issued 94 calls to action, including 7 placing responsibilities that rest in healthcare. The first 4 directed at the federal government, and there are 3 that medical regulators can act on to lead to real change. In 2021, the Federation of Medical Regulatory Authorities of Canada and all 13 provincial and territorial medical regulatory authorities in Canada issued a statement committing to taking action against Indigenous-specific racism. That same year, CPSM Council approved addressing Indigenous-specific racism in medical practice as a priority, meaning we would commit time and resources to advancing this important work. So CPSM formed a Truth and Reconciliation Advisory Circle that was led by Dr. Lisa Monkman. Guided by the advisory circle, CPSM has established and committed to 7 actions shown here. These recommendations have been endorsed by Council. So in 2023, CPSM issued an apology at the Special Chiefs of Assembly. Here, I just wanted to veer off a bit in regards to at the time that this apology is issued, I was sitting in the back and I was working as a policy analyst for AMC. So at the time, I was unsure on what was going to happen or if anything was going to happen. And I'm just very grateful to be on the other side now at CPSM, making sure that change is happening. So here we have the 3 calls to action. As you can see displayed 22, 23, and 24. 22 is more focused towards the Restorative Practices Program, where we call upon those who can affect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by Aboriginal patients.
So why this is important in Manitoba? You may or may not know about Jordan Anderson or Brian St. Clair. I hope that you do. But if not, I would very strongly encourage you to read up on these specific Manitoba stories. Jordan's principle comes out of an issue of systemic racism. And because it was, if we had to really simplify it, the federal government and the provincial government arguing over who would pay for which services for an on-reserve member, for a child. And because they spent so much time arguing, that child did not get to go home. So spent years in the hospital and years in Winnipeg. The other example with Brian Sinclair is more of an example of what are we allowed to get away with when there are no checks and balances in place. So you may be thinking, why do I have to do this? You know, why do I have to do the training? Why is this important? And this is a difficult question to answer. Some of you are probably in this webinar because you already know why. You have that answer within yourself. You want to be involved and you want to, you recognize that some things could be better. And some of you may be joining to find ways to validate your dissent. So I think the best way to answer the question is, why not? Why wouldn't we educate ourselves? Why wouldn't we try to change systems and be aware of biases that do damage? Not just psychological damage, but actual physical harm and death. As physicians, you may rely on your oath, stating I already swore to do no harm. That was one of the first things I did when I pursued this career. So why do I need to do more? And I would answer with, because you do harm by doing nothing. Stats Canada data shows that Manitoba's population has the highest share of Indigenous people at 18.1%, and Winnipeg is home to the largest Indigenous population in Canada. Several federal and provincial commissions and inquests have identified the need to address anti-Indigenous racism that exists in the healthcare system. Excuse me. There are documented cases that make headlines in the province and across the country of medical care that have resulted in serious harm. Data from the Race, Ethnicity and Indigenous Identity REI report released in June by Shared Health and the University of Manitoba's Algonquin Indigenous Institute of Health and Healing include individuals who identified as Indigenous were most likely to leave the hospital without being seen by a physician. For North American Indigenous people, substance misuse and mental health are among the top 5 chief complaints, which is different from the other population groups. However, the CTAS-2 scores indicate that these were emergent presentations and as such required attention within the same time frame as other CTAS-2 categories. So you have, I know this is a lot of information, but if you can imagine, your CTASs are the same, but yet the top 5 presentations, the way that they're labeled, are different. The REI data findings show that North American Indigenous and African and/or Black patients are waiting the longest to be seen. And Indigenous patients present to emergency departments with similar triage scores to white patients. In terms of understanding why this might be happening, there was a study in Alberta where emergency department providers stated that if the perception is that if First Nations patients are intoxicated, they'll be parked in a waiting room chair for 6 to 10 hours before seeing a doctor. They said that First Nations patients will usually disappear, so people just almost ignore them. So I want you to keep in mind that because of bias and undiagnosed racism, for First Nations patients, the perception is almost always that we're intoxicated. So if you come into an emergency department with somebody labeling you that perception as soon as you walk in, you can imagine that your concerns would not be addressed. You might not get triage, you might be completely ignored. So it's not just data, you have to kind of take it a step further and look at what the data can mean and how it impacts us.
So one of the first things that we did when we came together as a team was to develop a mandate statement. We will use the principle of restorative practices to uphold CPSM standard of practice, practicing medicine to eliminate anti-Indigenous racism, and commitment to action by engaging in meaningful, educational, and supportive conversations with registrants, members of the public, communities, families, and healthcare professionals to repair harm, restore trust, rebuild relationships, and prevent further harm through accountability, guidance, and healing.
Well, with that background and leading into our mandate statement, it's important to talk about what are restorative practices, because clearly we're very grounded in that. So I want to actually go back one slide, just sorry. So restorative practices are also called restorative justice. They've been taken primarily from the justice system, but they're heavily based on Indigenous practices of community building, relationship, and sharing. The way I always like to think about restorative practices and restorative justice is that they're different from our traditional approach to response to injury, response to harm, response to complaint. The traditional punitive approach says somebody has done something bad, so we do something bad to them to show them that doing bad things is bad. The restorative approach says a harm has happened, harm has been caused, harms create needs, and who is responsible to meet those needs, and how can we as a community come around them to support them in meeting those needs. So we go to the next slide. There's 4 core concepts within restorative practices. The first is active accountability. So all participants involved in a restorative process have to take a personal sense of accountability. They need to be responsible for their actions. They need to be responsible for their behaviors. We don't talk when we're dealing with a conflict of the offender and the victim, the perpetrator and the victim. We talk about the person who caused harm and the person who was harmed. We recognize that everyone has a role to play in the solution. With everyone being accountable, the next concept is inclusive decision making. So everyone is accountable for their own actions, their own responses, their own behaviors, but they're also included in the decision. This isn't being imposed upon them by outside, but participating in finding a solution to meet the needs of the individuals, to meet the needs of the community. Within this context, the restorative practitioner is going to provide support, they're going to provide facilitation, they're going to provide guidance, but the solutions are going to come from the participants in the process. With that, we lead to the core outcomes of restorative practices. The first being, we want to repair the harm. We're looking at healing. We're a healing profession. Restorative practices is a way to bring healing where there has been conflict and harm. And from healing, we can rebuild trust. So now we're rebuilding the community. We're getting everyone together to a point where there can be trust and there can be ongoing healing and ongoing community building from that point. So those are the concepts. How does restorative justice actually happen? And again, I mentioned at the beginning, drawn very heavily from Indigenous teachings and Indigenous practices. Restorative justice happens in circle. So we have, here's an example of a restorative circle. We have all the participants in the circle. I can't identify from that circle who the facilitator would be, but they'd be part of the circle. There's a centerpiece to provide a common point of focus for everyone in the circle. There's a talking piece that gets passed from participant to participant. That makes sure everybody is engaging in active listening. So when you hold the piece, you have the floor you can share. When you don't have the piece, you're listening actively to what's being shared around you. The facilitator is paying attention to all of that with my favorite word, multi-partiality. It's not even taking sides or not taking sides. It's being aware of everyone's perspectives in a multi-partial way to ensure that everyone can be heard and that we can look for how do we repair the harm and rebuild the trust. Now, restorative practices happen in different levels. So these are the 3 tiers of restorative practices. So the foundational tier, or tier 1, is community building. So as I've mentioned, this happens in circle, it happens in community, it happens in relationships. So we start by building community. So when there are departments, when there are regions where there has been conflict, where there has been harm, we can work with the community to engage them in sharing, to explore how they can move forward. The second level, tier 2, are responding to harm and conflict. So here again, we have the person who was harmed, the person who caused the harm, their supports, coming together in a circle to talk about what the harm was, what the needs were created, and how we can support restoration of that relationship. The final level of tier 3 is reintegration. So this is where we have had a separation. So this is where someone has been cut off from community, someone has been suspended from their practice, and now they're coming back. And the goal here is, how do we as a community come around that individual to support them back into their role in a way that they can address the needs that they have, they can address the harms that were caused, and move forward again in a trusting and safe relationship.
How does our practice standard work towards addressing the concerns that we are well aware of? We all know that action is needed to address the inequity and the harms that are inherent in the systems of care that we provide. The practice standard is how we can, as a profession, show how we can make a positive change and reduce the harms and the inequity that exists This is a starting point. This is where we show up as a profession and show our leadership in making the positive changes that are needed to advance. Education and learning about restorative practices and restorative justice is an important starting point, and we appreciate you for being here and thank you for attending our webinar. Learning about anti-Indigenous racism and ways to address it are important for our profession. It's important for our staff perspective and understanding and to learn where our gaps are. We all have biases that impact us at work, at home, and our social lives. But we need to think about the patients that we're caring for and how these biases affect them. There are three main aspects to the practice standard. The first is recognizing and acknowledging that racism exists and impacts the health of Indigenous people disproportionately. This is a reality. The life expectancy and the burden of illness is much greater in Indigenous peoples. Next, we need to reflect on that and learn where our own personal biases are and take action to address the racism that we see through advocacy, upholding the code of ethics in our profession, and ensuring that we are up to date with education in addressing the issues. Our Restorative Practices Program is embedded in the quality department. And we take an educational and supportive role, and that is the core of what we do in the quality department. We are here to help our profession, the registrants who we regulate, and to maintain and uphold our self-regulation. Accountability is the core of self-regulation. Complaints are addressed elsewhere. So where there is a significant concern that is not amenable to a restorative approach, that would not be something that would be maintained in the quality department. That's a different process. But where we can provide education and support, advocacy and outreach, we will address it in the Restorative Practices Program in the quality department.
So our team came together in April, and in order to start our work off in a good way and in the right way, on June 6th, we held a sacred pipe ceremony titled Manitoba, which is They Come Together. This was done to mark the beginning of a significant shift in how anti-Indigenous racism in medical practice is regulated in Manitoba. It was important to be able to have something like this to set our foundation for the program. This sacred ceremony was to connect to the spirit world, ensuring that we acknowledge the ancestors who helped guide us on this new journey, and they are there to support us.
So we've talked a lot about the underpinnings of our restorative practices, how we got here, but it's important to now look at what have we done since we got started? Who have we engaged with? How have we been engaging? So probably the first thing to talk about is the cultural safety and anti-Indigenous racism training. So this is a key part of the education in the standard that was introduced. It officially came into effect on June the 21st. So all registrants are required to have completed cultural safety training course by October of 2027. And the training needs to be repeated every 5 years. So when it was introduced, there were 4 courses that were included in the mandatory training options. So these are the 4 options. So one of them is the Ongamazin developed course, We Will Take Good Care of the People. The PAP, which is supported by Doctors Manitoba. The Sanyas course, which originated out of British Columbia. And the Indigenous Health Program for undergraduates at the University of Manitoba. So these were the 4 courses that were part of the standard. If you happen to have done one of these before December 18th, 2024, that will be considered to have met the requirements with a 5-year, so you need to repeat it. So if we go to the next slide, one of the earliest emails we started getting, and the questions we started being asked when this was released, was what else could be effective training? What else could be qualified training? So we've had a lot of questions about other programs that could be acceptable. I will start by saying I appreciate everybody's here and I hope you're learning a lot from this, but this webinar does not count for your mandatory cultural safety training. What we have done is when we get requests to consider other courses, There are core things that we look for. Really, the first is engagement. It needs to be a program that requires participants to actively engage with the material, to think about it, to process it. It isn't a 45-minute webinar where you can be exposed to lots of things and learn them, but not actually engage with it. It needs to look at the historical context of colonization, the underpinnings of systemic racism in Canada. It needs to look at those things. It needs to really consider that important context that underpins what we're talking about. And it needs to have a focus on anti-Indigenous racism in healthcare. So when we look at other courses, these are the things that we're looking for. If you have questions about a course you may have done, please email the program. We're happy to take a look at it. In terms of reporting this, it'll be a question on the annual renewal that starts up very soon. So you don't have to email us your certificate. You can report on the annual renewal, and it'll be tracked that way.
So in our brief period of existence, we've already seen 23 different referrals. We know this approach is working because people are engaging with it in just a short time. 6 referrals are waiting before the program even started, and we're currently at 23. For myself, I think that we will see this number increase exponentially. And when the program is more established and when we actually get to start to talk to patients and to the communities, I think that a lot more things will start to come forward. Right now, we hear a lot from people in our profession, but I fully suspect that other people will feel, validated to be able to tell their stories and to share. And I think it, for me, very, very exciting that we actually have somewhere to call, that we have someone to call, we have someone that we can reach out to if we see an issue, if we experience something ourselves, if we notice something in our emergency departments or when we're in training or we're in clinic and community, wherever it is. It can be comments, if something doesn't sit right with you, you finally have the ability to call somebody. And that has never happened before. So for the first time ever, the college has admitted and agreed that they're going to listen and that we need to do something about this. And it's the first college in Canada to do so. And from my own personal perspective, as a First Nations person, I can't tell you how much it means to our populations that we might be believed. That when we have a story to tell, or we want to share about a harm that's been done, that somebody might actually believe us.
So here's a picture of our team. We had the opportunity to go to a community, which is very important in the work that we're doing. So for the next while, that's something that we'll be doing, is focusing on community engagements and being able to build those relationships. So here we have the opportunity or invitation, to the Manitoba Harm Reduction Network, their Overdose Awareness Day on August 29th. We set up a booth and it was really great to be able to network and to see other people there.
Sure. And I was just gonna, at this event, it was great, similar to what Courtney was just saying about how people see the college in a different way, that we're here to listen and we want to know. We had feedback from participants and exhibitors at the harm reduction rally saying how pleased they were to see the college there. This was not where they would necessarily have expected to see the College of Physicians and Surgeons, but they thought it was really important for them that we had that kind of stuff here out there. There were a few physicians and some patients. The picture there is our team with Chief Blue Sky, and Tara brought him over and had him come and talk to him a little bit about what we were doing. He came over and he had the best question, which is so what should I tell the other chiefs if they ask, and before I even had a chance to answer, he also, I remember there was an apology in 2023. He said, well, what happened after? And it was great to be able to say, well, this is what happened after. And we're here to listen, and we're here to hear the stories and to facilitate healing and to facilitate conversations. And he said, great, that I can take that back. So that it's so, again, validating for us in the early days of what we're doing to be getting that positive response, and I see people being encouraged, and that encourages us.
We're here to support you, our registrants. Education and support is at the core of what we do in the quality department, and that will be the same in our Restorative Practices Program. We know that supporting our registrants puts them in the best position to provide the best care for patients. And we know that there are systemic issues, and we're here to listen as well and to shine a light on those issues that may be impacting you and preventing you from doing your best. We want to hear from you. We are here to help. And as was mentioned, a big part of what we're doing is outreach. We will be going to all of the different communities across Manitoba to listen, to hear what you're doing and how we might be able to help you. So we look forward to meeting some of you face to face in the future. And as was mentioned before, please feel free to call or email us anytime if there's anything we can do to help you.
So, you know, we talked a lot about how we got here, and it was clearly not a straight path. But we recognize that reconciliation is not a one and done, it's an ongoing process. And it doesn't have a clear endpoint. And this is a wonderful quote as we kind of focus on how we got to where we are. And you know, the Justice Sinclair called upon all of us to climb the mountain. And the college and the Restorative Practice Program, we want to come alongside to help you with that climb.
So what should I do? And if anybody knows me, I never tell a story. So this is what my mom used to say to us. I have 3 sisters, and we would talk about all sorts of issues all the time. And I know some of you probably heard me tell the story already, but we would sit around the kitchen table or wherever we were, and we would, you know, complain, right? We complain about things, but then she would be like, well, girls, what are you gonna do about it? And so this is just sort of my approach to life. And now for you guys, what should I do? You've been given history, you've been given some knowledge, you're gonna do your course, and then you have to think, how am I gonna put this into practice for myself? But the easiest things that we can do would, so first, be accountable. Be curious, be an advocate, and believe. That for me is the biggest one. And when your patients, your Indigenous patients know, and then probably all your patients know, that you believe them when they talk to you and when they tell you a story, it goes a long way to building a really, really strong, solid relationship.
So I just wanted to reiterate that change begins with you. And the reason why we put the 4 direction circles, you see 4 of us here, but we also have somebody else who's our program coordinator, Lauren. So the 5 of us all together, we kind of all represent 4 different colors. And I just think that's very monumental in the work that we're doing.
Wasn't that?
Yes, it wasn't.
All right, well, that brings us to the end of the formal part of our webinar. So again, I want to thank everyone for listening. We have lots of time to take your questions. Our email address and phone number are up there. So any questions you have about restorative practices, about what we do, about where we might be able to help, about the cultural sensitivity training, please don't hesitate to email us. Also, I know, you know, Courtney had mentioned we're out there. We know this is just the tip. 23 is the tip of the iceberg. We have brochures and business cards about our program, so we're happy to supply those to your clinics. So you can leave them available because, you know, your patients can see this and they can see things and ask, and we're open to hear from them. So if you'd like to get some materials to put in your clinic, please let us know. We're happy to provide those so that we can empower you and empower your patients to reach out.
And I think it's not just, it's not that we're asking you to teach your patients about the program, that sometimes even just having the card there or having the brochure is a little bit of symbolism that can go a long way. So yeah, if you want any of those resources, please let us know.
So we do have one question. Can you give an example of one of the 22 referrals, what happened or happens to address it?
I mean, that was one of the things we talked about earlier, was whether we should go into the types of referrals. I mean, we can talk about the themes, but you wouldn't want to give anything specific because you do have to protect people. And sometimes people are still afraid to speak up. Because sometimes if you speak up, then you could be punished, or you could be ostracized, or you could be singled out, and you worry. And I'll just tell you that when I heard that they were doing like with the data collection about identifying as Indigenous when you go to the hospital, the first thing that I thought was, who the heck would do that? I would never do that. I would pretend to be as white as possible when I go to the hospital. But I mean, I recognize how important it is, but I mean, you have to understand that there's some fear there. So I guess generally, sometimes it will be physicians who work within different regions or different health centers, health settings. And sometimes it's patients who will bring up concerns of how they were treated or language that was used. The first thing we do is reach out and acknowledge that, you know, we've received your referral, and basically try to set up a meeting, right? And talk to them and get the story, and then do maybe a little bit more, not so much investigating, but collecting those stories of other people and other people involved, and then trying to bring it together in a circle where everybody can share their perspectives, try to come up with solutions of how are we gonna move forward, and then how do we revisit this in the future, see if it's worked.
There's maybe a couple of, to add to that, I think we're hearing from we're hearing from patients, we're hearing from practitioners about their experiences, about things they've witnessed. I mean, that was a great kind of description of what we want to do, but I think, you know, 2 points. One of them is, in that first conversation, one of the questions that we will ask is, do you want to do anything with this? Some of the people we've heard from really just want to be heard. And when we've had a conversation, we say, do you want us to speak with this other person you've mentioned? And sometimes they say, sure. And other times they say, I'm not ready. In which case, if they're ready, we're open to it. And sometimes they just say, no, I just needed to be heard. So that's part of that active accountability. The other piece, and it goes a little what Dr. Bruin had mentioned, is we do have kind of priority criteria. So if what we hear is going to directly impact patient care or patient safety, it's going to impact a patient or family in a significantly negative way, that's not going to stay with us. That's going to be a referral on for a more urgent type of investigation. So we are also looking at the very beginning to go, is this appropriate to restorative practices? Or is this a harm that needs to be addressed in a different way? Because I think we recognize the power. We want to help people, we want to teach, we want to educate, we want to build relationships, but there will be some situations where what needs to happen is addressing a harm that was caused, or a medical mistake that happened, or something else that isn't really appropriate for a quality lens, but actually needs different lens.
Next question, how can we get the word out about this, particularly to groups that need it the most?
Okay, I can start and then other people can start. So, I mean, we have the cards in the brochure, so just putting them in your office and having them available gets the word out. You know, the outreach we did at the harm reduction fair, we realized very quickly this was the first outreach of what will be many. And being out there, you know, in connecting with Chief Blue Sky, the hope is that he will be able to build some connections for us within the Indigenous organizations. We've talked about the value of going out to health fairs and being out there. We've talked about QR codes that we can put out there so patients can scan and share an experience. So we're looking at all those. We've also, you know, you heard from Dr. Bruin about reach out to the different regions, and we're planning to do this out to the regions. But really, we're in a stage now of getting the word out there that we're here from as many different venues with as many different connections as we can. So building those networks, building those connections.
I think that, I mean, that we'll talk to, we'll hit the physicians, right? And we'll hit the nurses and we'll hit the organizations. But if you want to hit the people, you want to hit the people. But if you want to get to the people, yeah, it's those grassroots movements. And luckily, I think that, you know, with myself and Tara, we have some connections there, and we know how the word spreads. And, you know, we still use a lot of social media within our populations. And I think that'll be a really powerful tool for us. And then also just getting out there to not just health fairs, but community events and powwows and hockey tournaments and basketball tournaments and all the things where I know our people are. So, we'll be there.
Is the path, your journey through Indigenous Canada, the only course we must complete before October 22nd, 2025?
So the path is one of the 4 that we've approved. So it's not the only one you have to do. You have to do a course. So the 4 that we've approved, as what we mentioned, the Ngomazin Health one, the path, the Sanders training, or having gone through the U of M. Or if you've done an alternate one that you think would qualify, let me know. It's not due by October 22nd, 2025. You actually have until the October 2027 renewal is when the requirement actually comes into force. If you've done it already, that's great. You can start reporting this year. Anything done after December 2024 would count towards fulfilling that requirement with the 5-year qualifier. But yeah, the path is one of the 4 that are pre-approved, but one of the many out there now that, as I've read them, a lot of them are very promising. Some of them are good, some of them are great. I do want one other thing I want to actually, because it was a question that had come up early on, is with all the training, we had a few people say, I practiced in a primarily Indigenous community before. My practice is mainly Indigenous patients. That's fantastic, but that doesn't actually qualify for the cultural sensitivity training. We still want you to take the course and have that educational piece that goes along with it.
Are other licensing authorities undertaking these important anti-Indigenous racism initiatives?
So, yeah, I can answer that one. So this is a huge discussion across the country. We do work together and share data and information, but Manitoba is leading the way in terms of moving forward with an actual practice standard. Other provinces have guidance for registrants, but don't have a component of mandatory training, nor do they have an active program to assist registrants with concerns. So people are looking to us. We've actually been across the country in multiple ways and actually internationally presenting the program. And people are looking to us for answers. So we do work closely with British Columbia, which has done a lot of the research in Indigenous racism, and have worked collaboratively with other provinces, but we are the first to have this program.
When will I be due for retraining?
5 years after you finish the training. So if you've just done it, like if you did it before 2024, it'll be that if you did it before 2024, you have to do it now. Or sorry, you've done it by December 2024, it's good, and you've got until 5 years from then, so that'd be 2029. If you've done it anytime since then, it's 5 years after you finish. So if you finished a week ago, you've got till 2030.
How long does it take to do the path?
So I did the path. It takes about 6 to 8 hours. Again, part of engaging with these courses is don't try and do them all in one sitting. Spread it out over time. So you can do it over time. It took me about 3 or 4 weeks. I did a little bit every day and worked on it through it. The Ngomazin course, I'm working through that one. It takes a little longer. It's probably closer to 8 to 10 hours, but again, you can spread it out over weeks. So take your time. I mean, I really encourage people to, when you're doing it, take your time, engage with the material, think about it, reflect on it. Don't just try and power through the slides so you can get a certificate at the end.
Take your time to reflect. Like our elders always say, what you get out of it is what you're willing to put into it. So, yeah, it might be good to do a little bit, take some time, reflect, look around you. Maybe look through different eyes at the world around you and how you practice and the things that you see, and then go back to it.
And with that, I just want to thank you again and wish you all a good evening and thank you for joining us.